Ben henüz 1 yıllık bir uzman.
I am just an expert for the last 1 year. I prepared that. And I'm sure that you will understand it by the end of the presentation. This is the third subject of today. I will be talking about female patients with sexual dysfunction. This is an important life part of the women, and in practice we see this issue a lot. Sexuality is an important part of human life and plays a vital role in maintaining well-being and health. And a satisfying sex life is also an important component of a marriage. During the menopause, adulthood, pregnancy, and at each time period, it should be evaluated differently. Sexual health, how does WHO define it? A state of physical, emotional, mental, and social well-being in relation to sexuality. It's not merely the absence of disease, dysfunction, or infirmity. We can add culturally, and also we can say that continuation of well-being. Sexual dysfunctions. Masters and Johnson, I want to underline them because the sexual response models, they defined them in the experimental environment, and they defined the cyclus: desire, excitement, orgasm, and plateau. And afterwards, in 1974, Hedon Singer Kaplan, he evaluated the issue clinically. The desire phase was also added. And in sexual response cyclus model, desire, stimulation, orgasm phases. After this physiological natural definition, then sexual dysfunctions can be defined better because the definitions are being made on the basis of the dysfunctions of these phases, and the treatment model is created again on the basis of these phases. And modified cognitive behavioral couple therapy is the way to go for the treatment of the sexual dysfunctions. Chronologically, if you look at that, the sexual disorders in psychiatric classification systems, in DSM-2 for the first time, psychophysiological disorders, genitourinary disorders, in ICD-9, sexual deviations and disorders, in ICD-9 CM, psychosexual dysfunction, in DSM-3, psychosexual disorders. You can see the names in the DSM-3R, sexual disorders, in ICD-10, non-organic sexual disorders, and in DSM-4, sexual disorders. From DSM-4 to DSM-5, there are many changes, but the most important one in DSM-5, specific to the sex, male or female, female sexual interest, sexual disorder, and there are sub-definitions were made clear in DSM-5, and if we are going to make a diagnosis according to DSM-5, we need to be knowledgeable about getting a sexual history and story, because here we are talking about a specialized field, so sub-definitions are also very important. What are they? Is it lifelong or acquired or wide or situational or partner factor, relationship factor, cultural, religious, medical factors? We need to be evaluating all of them, and their objective measurements in terms of the period, frequency, and also satisfaction level. And there are some changes in terms of the definitions. Hyperactive sexual orders and the stimulation sexual orders. The name was changed and taken under one order. Orgasm disorder, dyspareunia and vaginismus, they're under again one title. Genital pelvic disorder, sexual disgust disorder was omitted. And the other sexual disorders, defined ones, and the non-defined sexual disorders is the another title. This is the prevalence of sexual dysfunction disorders. These are the average numbers, and we don't have much difference with the rest of the world. There are some problems about the samples because the subject is sexual. So you can see here different percentages, but in the world 31% among male, 43% among female, and in our country 40% male and 45% female sexual function disorders. This is the prevalence. The prevalence didn't change, but there's an increased awareness of patients. There's internet, social media. People get more information. They have easier access to the information. We are becoming a more open society. And of course, there's the reflection on the patients as well. And increased patient consultation. This consultation is not only goes to the professionals. They go to the magicians, they go to the hodjas, they go to the sexual therapists, they go many people. But we can say that there's an increased patient consultation for us as well, an increased number of sexual therapists and treatment centers. The number of the centers increases as well. But it is not possible to say that they meet the need, because the data shows us that appropriate referrals of patients by healthcare professionals at the first consultation has a key role. It might take 3 to 6 years. When they are within the health system, the patients, when they go to the family physician or the gynecologist or urologist, they should be guided in a proper fashion. I think we can interfere with that. And there is this question, yes, okay, they're going to be guided well, but who and to whom? And I think there's a problem in that regard. Sexual desire disorder is the first one, and the vaginismus is the second one, but we can say that vaginismus is the highest referral amount, 56%, and between 43 to 73% leading cause of consultation on sexual dysfunction in Turkey. And it is around 5 to 70% in the Western world. But I would like to say that by a standard therapy of 6 to 10 sessions over 2 to 4 months, success rate of more than 90%. But the continuity of the marriage can be jeopardized if it is not treated. And when we look at the etiology, 84% of the etiologies of non-completed marriages, it is resulted by the vaginismus, and within 2 to 4 months vaginismus can be treated successfully. more than half of the patients are coming with vaginismus, and if we can focus on them without the sexual therapist, we can provide an efficient therapy. When they go to the family physician or urologists or the gynecologists, our outpatient clinical experience within the last 1 year, but as the psychiatric clinic, what do I do with these patients? They should come to me, and within the last 1 year they came to me, and what did I do? Erectile dysfunction. I sent them to Erenköy sexual disorder polyclinics, hypoactive sexual desire disorder. 2 of them had major depression disorder, and the other one I directed them to Erenköy. Premature ejaculation, 1 male, and I directed them, and I am following their treatments from time to time. We can follow them through the sexual disorder polyclinic and the vaginismus cases. I followed them. During my assistantship, I got sexual disorder training. I'm not a sexual therapist, but I was interested in vaginismus, and when I was assistant, I took training from JETA and supervision, and we followed patients together. And I had to be brave to help them, and I took vaginismus cases. So what happened? Couples married from 3 weeks to 1.5 years. Sometimes they can come 3 to 6 years later, but they can come to psychiatric polyclinic. You see that. So early consultation is very important. No sexual intercourse yet. Teenage female 25, male 29. We did interviews. Then we started accepting them for the couples therapy. 2 couples, they didn't continue. One of the spouses, he didn't come to the seances, and there was relationship problem with the other couple, and they discontinued. And we treated 3 couples successfully, and we are still working on 5 more couples. To sum up, sexuality is an important part of our lives, and we see sexual function disorders more frequently. And when we discuss with the expert friends in that regard, they don't know what to do. I have a colleague in Kütahya, she was here. She's interested in vaginismus, and she stated that she accepted patients from neighboring cities, 8 to 9 psychiatrists, for example, in a hospital, but they don't have any interest in the sexual function disorder. Therefore, people living in that city go to other cities and other centers. And sexual therapy centers, there are, I think, 8 sexual function treatment centers. These are the state-owned, and it is difficult to have an access, and the cases might be complicated while they wait, especially in the vaginismus. If they can be trained at an early stage, it is possible to interfere with the disorder, and it can be treated very easily. And DSM-5 is also focusing on the sexual function disorders, and within that framework it should be handled in a more delicate position. I would like to finish my presentation with a message. Sexual dysfunction treatment training in psychiatry specialty provides effective intervention to early consultations. The professors and the assistants should be more involved in this topic, and we can be more fruitful in that regard. Thank you very much. And I would like to finish my presentation with a poem which is not going to be translated by the interpreters.
Fethedilmeyi bekleyen kale daima. Gecenin karanlık koynunda kapılarını açan kent, en fazla bir sandalı koynuna alan deniz. Durağan ve çaresiz ve lekesiz ve temiz, tertemiz. Adı tarihe geçmiş ve geçecek, dişil ve doğurgan. Kadın ve kız olan yani ki. Yani ki bütün hikayelerin baş kahramanı olan. Dünyanın çevresinde döndüğü asıl güneş. Çağların gerçek sahibi, gerçek yazıcısı tarihin. Bir anda en güçlü hükümdarları yerle bir kılan, en güçlü kumandanları köle, en zelil köleleri hükümdar kılan. Tutsakları en derin aydınlıkta hür, hür olanı en koyu karanlıkta tutsak kılan. Hükümsüzü birdenbire hükümlüye çeviren, hükümlüyü birden hükümsüz eden. Geçer akçeleri geçmeze, geçmez akçeleri geçere dönüştüren saklı ve gizli el. Ama güçsüz. Çünkü daima ödeyen ve ödenen bedel. Teşekkür ediyorum.